Okay, it's 8 o'clock. We'll get started with grand rounds. It's so great to see so many of you in person. We were just saying, I'm very glad grand rounds is today and was not yesterday. Would have been a very different challenge for all of us to get there. So we are very delighted to have our own Dr. Pulia giving grand rounds, and to introduce her, we have Dr. Asthana, our Division Chief of Geriatrics.
Thank you, Lynn. Hi, good morning, everyone. I want to welcome and thank you all for joining today's grand rounds. It really is a pleasure to introduce and then invite Dr. Nicole Rogus-Pulia, one of the stars in our department, to make her presentation. Dr. Pulia, as you know, is a speech-language pathologist. She is internationally known for her research in dysphagia in patients with neurodegenerative diseases, especially Alzheimer's disease. She received her master's in speech-language pathology from University of Iowa. Then she went to Chicago and did a PhD from Northwestern University in communication sciences disorders. We were then lucky to have her here in Wisconsin. She came here to do her postdoctoral fellowship, both of them at the Madison VA, first as a women's health fellow with Dr. Carnes at the Madison VA. And then she joined the Madison Grech Advanced VA Fellowship and performed her work in dysphagia. Dr. Pulia, besides an assistant professor of geriatrics, also is a research health scientist at the Madison Grech and has an affiliate faculty appointment in the Division of Otolaryngology of the Department of Surgery. Dr. Pulia, as you can imagine, is a recipient of multiple awards and honors. And obviously, I can't go through all of them, but just to name a few of them, she received the Central Society of Clinical and Translational Research Early Career Development Award. She also received the Rick L. Bollinger Clinician of the Year Award from the Association of the VA Speech-Language Pathologists. And then she recently received the Distinguished Postdoc Mentoring Award from the University of Wisconsin Postdoctoral Association. Dr. Pulia has multiple NIH and other peer-reviewed grants. Just to name some of them, she is a recipient of the prestigious NIH Beeson Award, which is the Career Development Award for clinicians. Only about 8 to 10 clinicians across the country get this award every year. And she is one of the recipients of the prestigious Beeson Career Development Award. And she is got a R1 pending as a PI that received a 10th percentile. So that award is about to be noticed anytime. She's also an MPI on another NIH grant, which relates to imaging of the swallow mechanisms. In addition, she's co-I on 4 NIH grants. As you can imagine, overall, Dr. Pulia has about 7 or 8 active NIH-funded grants. In the past, she's received additional 10 grants. In terms of publication, she's one of the very and most productive scientists in our department and the division. To date, she has published 47 papers, and she is first or the last author on 26 of them, and she has another 8 papers in submission. Dr. Pulia is one of the most sought after speakers in the country in dysphagia, and she has to date made 100 invited presentations, about 80 of them nationally. And that is really a testament to the recognition of the work that she does in dysphagia. It really is a pleasure to invite Dr. Pulia to make a presentation. Thank you.
Thank you so much, Dr. Asthana, for that kind introduction. I'm so appreciative. I'd like to start today by introducing you to Paul. Paul is an 83-year-old patient with a diagnosis of dementia who is admitted to the hospital with a urinary tract infection. During routine clinical care, Paul's nurse notices that he's coughing on and off while he's eating breakfast. So she mentions this to the medical team, and the medical team puts in a consult to speech language pathology. The speech pathologist then comes and performs a clinical evaluation of swallowing, follows up with a video fluoroscopic swallow study. And Paul, despite having no prior history of dysphagia in his medical record or self-report, is diagnosed with dysphagia. And recommendations are for thickened liquids and a pureed diet. Subsequently, Paul is then discharged to a long-term care facility. And as the provider, he returns to your clinic a couple of months later for follow-up and is showing signs of poor oral intake. I'm sure that this clinical scenario is familiar to many of you, and it's a very difficult situation because we know the serious consequences of dysphagia, but we're also balancing our decisions about dysphagia management with issues related to quality of life and also to care. A little closer. Here you can see some quotes from a survey study that we're actually still currently conducting of providers who are focused on geriatrics care. And you can see here that there are definitely some concerns from providers over these recommendations for modified diets. So there's even the word fear is used in this first quote, fear of modified diets that are recommended, and the perception that these are the only recommendations that are being carried forward for our older adult patients. There's concerns that dietary recommendations can significantly affect quality of life in our patients, and also about the downstream implications of placing patients on these modified diets, because these issues need to be considered in light of those of care. So building on this, I titled my talk today, Beyond Thickened Liquids, Advancing Dysphagia Care for Vulnerable Older Adults. Regardless of your medical specialty, I'm sure you have all faced similar clinical situations. So my goal today is to address some of these perceptions and also to offer a path forward based on our ongoing research. By the time we're done today, I want you to be able to define what are age-related changes in swallowing function and associated health consequences. You should be able to discuss compensatory and rehabilitative intervention approaches for dysphagia in older adults. And I'd like you to be able to differentiate reactive from proactive approaches to dysphagia management. So in order to get you there, here's what we're going to cover. First, I'm going to talk about these age-related changes in swallowing. Next, I'm going to provide an overview of dysphagia and its consequences. Then we'll get into specifics of the different intervention options that we can offer. We'll talk about the difference between reactive and proactive approaches to care, and then I'll provide a summary and some future directions for our work. Okay, perfect. Sure, of course. So we'll get started by focusing on age-related changes in swallowing. I didn't put this image up here to take you back to gross anatomy and to scare you with this netter image, but rather just to highlight that swallowing is a complicated process. It involves precise coordination of 50 different muscle pairs and 6 cranial nerves. Traditionally, swallowing was thought to be an invariant reflex. However, due to more recent imaging studies, we now understand that the swallowing neural network is actually quite diffuse, and that swallowing is a patterned response that changes depending upon the characteristics of what we swallow. And we actually swallow 600 to 1,000 times a day. You probably won't even notice how many times you swallow if you're drinking something or eating this morning during the course of my talk without even being aware of it. Here is a video fluoroscopic swallow study image. This is our most commonly used diagnostic method. And this example is from a healthy young woman who's swallowing. And what I would like you to notice in this image, first, the red arrow is pointing to the esophagus. The dark material that you see being swallowed is barium. It's radio opaque so that we can see it on the X-ray images. And I'd like you to notice that this material is moving quickly through the mouth and throat into the pharynx without anything being left over in the throat after the swallow, and nothing is entering the airway. We know that the process of aging itself can influence the swallowing mechanism. In fact, the systemic factors that lead to sarcopenia, or changes in muscle mass and quality with advancing age, have been shown to impact the swallowing related muscles of the head and neck. Specifically, these include the tongue, the muscles of the jaw that we use for mastication, the suprahyoid muscles, and the muscles of the larynx and the pharynx. One way that we can assess this is by tracing the area of the pharynx on the video fluoroscopic swallow study, which doesn't seem to be showing up here, but we can actually trace the area of the throat on the swallow study, and then we can do that at rest before an individual swallows, and we can also look at that at the height of the swallow. And this gives us an idea of how the area of the pharynx or the throat changes during the swallow. And studies have looked at this in young, healthy adults as well compared to older adults, have shown that the pharyngeal lumen, or the area of the pharynx, actually expands as we get older due to reduced muscle thickness in the pharynx with advancing age. We also know that age-related changes in sarcopenia can affect the muscles of the larynx, specifically the thyroarytenoid muscle. In the image here on the left, you can see an example of full vocal fold closure. And then on the right, you can see a gap between the vocal folds. We call this glottal insufficiency. And we know that the frequency of glottal insufficiency increases with advancing age. There are also studies that have examined the cross-sectional area of the geniohyoid muscle, and they have used CT imaging to do this. And they've shown that this cross-sectional area, which you can see GH in this image, decreases with advancing age. The tongue is a particularly important structure for swallowing in that it controls what's being swallowed, it moves it into the pharynx, and it creates positive pressure generation to get that material from the mouth into the esophagus. Studies have shown a reduction in tongue muscle fiber diameter with advancing age, and these MRI images of a younger female compared to an older female demonstrate the changes in tongue mass and composition that occur with advancing age. In addition to these changes in muscle mass and quality, we can also measure the force generation of swallowing related muscles. We can measure the maximum pressures that are produced by the tongue by placing an air-filled bulb along the surface of the tongue, asking the individual to take their tongue and press up against the roof of their mouth as hard as possible. This gives us an idea of what the maximum force generation of the tongue is for that individual. These maximum lingual pressures have been shown to be positively associated with other measures of physical function in older adults, specifically jump power and height on jumping mechanography, as well as hand grip strength. So when we're thinking about the consequences of dysphagia clinically, one of the main things that we are concerned about is what we call the safety of the swallow, which refers to the occurrence of material entering the airway during the swallow. Not sure why it's not showing the image here, but there are two types of airway invasion that we think about when we're assessing clinically. One is what we call penetration, which is when material enters the airway but doesn't move below the level of the vocal folds. The other is aspiration, which is when the material moves into the larynx but is below the level of the vocal folds into the trachea and down into the lungs. This image here is showing you an example of another outcome that we assess called oropharyngeal residue. This just refers to material left over in the throat after the swallow. In this image, you can see an example of residue in the vallecular space as well as in the piriform sinuses. And this residue is particularly concerning because after we swallow, we initiate breathing. And so if any of that material is in your throat, it's then at risk for moving into the airway and being aspirated. You'll also hear this referred to as the efficiency of the swallow, because we're thinking about how efficiently the food or liquid is moved through the pharynx and into the esophagus. See if this will play for you here. So this is another video fluoroscopic swallow study, but this is from an older adult instead of a healthy young adult. So what I'd like you to notice here inside the red circle are some of the effects of those aging related changes that we talked about. Specifically, you'll notice that some of the material is penetrated. So it enters the top of the larynx, but doesn't move down below the vocal folds, resulting in aspiration. There's also a small amount of residue left over in the molecular space, which is where the base of tongue meets the epiglottis. And while this is still considered a functional swallow, you should be able to notice that there are some subtle changes in swallowing in this older adult. In contrast, in these images from a 74-year-old female with post-stroke dysphagia, you can see again in the red circle an example of aspiration where material moves into the airway, but this time below the level of the vocal folds. There's also more residue in the molecular space. If I can get that play again for you. There's more residue left in the molecular space and also along the surface of the larynx. While we know that dysphagia is highly prevalent in older adults, we also know that the dysphagia prevalence varies by setting. Our lab recently completed a study assessing the prevalence of dysphagia in older adults in the Wisconsin community across the state of Wisconsin who were community dwelling and receiving meal support through Meals on Wheels. And we found that prevalence of self-reported dysphagia symptoms in this population was 20%. We know that the prevalence is higher in institutional settings, up to 52%. And based on some preliminary data from an ongoing collaboration with the Department of Emergency Medicine, we have an estimate of 73% prevalence of dysphagia in older adults presenting to the ED with a suspected community-acquired pneumonia. And so based on these findings and other factors, it's been suggested recently that dysphagia be considered its own new geriatric syndrome. Dysphagia has also been shown to occur more frequently in older adults who meet the criteria for frailty. One study showed a higher occurrence of dysphagia in hospitalized patients who were classified as being pre-frail according to the frailty index score, and an even higher occurrence in those who are defined as frail. The co-occurrence of dysphagia and frailty was associated with multiple poor outcomes in these patients. Additionally, maximum lingual pressures have been shown to predict frailty status as well. So as described previously, we know that sarcopenia can lead to increased risk for dysphagia, which then results in malnutrition and dehydration, which contributes to the onset of frailty. Additionally, malnutrition and dehydration may lead back in a cyclical fashion to worsening sarcopenia. However, the traditional criteria for frailty have not included factors that are related to oral health and swallowing traditionally. So in order to address this, we collaborated with professionals from several different institutions to develop a framework for how we can think about oral health and swallowing in the context of frailty. We know that the onset of frailty requires there to be a disruption in the balance between the amount of physiologic reserve we have across multiple systems in our body. And this includes the systems that we use for sustaining nutrition and hydration. And when that balance is disrupted, that's when individuals are at highest risk for developing frailty. And here you can see that illustrated. And so we developed a model that brings attention to these different factors of oral health and swallowing, and also shows how they're related to other factors traditionally associated with frailty. So now that we've reviewed these different age-related changes in swallowing, we will move on to discussing dysphagia and its consequences. So when we have an individual who's operating at a place where their functional reserves for swallowing are low, and then they experience a negative health event and possibly a hospitalization like that clinical scenario I set up for you in the beginning of the talk, they're much more likely to develop dysphagia if they've already had some of these age-related changes. We know that dysphagia results from a variety of medical conditions, and you can see some of those listed here. Additionally, dysphagia is associated with a whole host of negative consequences, including both aspiration and non-aspiration pneumonia, dehydration, longer length of hospital stay, increased caregiver burden, hospital readmission. The images are off a little bit here. And most importantly, dysphagia can affect quality of life for our patients. So if you just take a few minutes right now to think back over the past week, how many of the different activities, now that we're having more social interaction with others in person, how many of the different activities that you've been involved in have been around the process of eating and drinking? And then if you can imagine that you aren't able to swallow effectively. So every time you sit down to share a meal with your family, you have to remove yourself from the table and run to the bathroom in order to expectorate things from your throat. And we even have some patients who walk around with a cup so that they can spit out their saliva because they're not able to swallow it. So while these health outcomes obviously are of great interest to us from a prevention standpoint, it's also very important to understand the significant effects that swallowing disorders have on our life more broadly. So what happens when you make that referral to speech language pathology for a swallowing evaluation? The first thing that we're going to do is we're going to complete a clinical swallowing evaluation. So we'll do a review of the patient's medical record. We'll determine what sort of health conditions they have already that may predispose them to dysphagia. And then we'll perform a clinical examination that includes an oral mechanism review. And that will help us to determine how the nerves that are responsible for innervating swallowing and also the muscles involved in swallowing, how they're functioning for the patient. We will also administer a patient-reported outcome tool. I know it's appearing small here. Hopefully on the slides that you'll have access to, you'll be able to see it larger in case it's of interest to you. The most commonly used validated questionnaire is the eating assessment tool, or the EAT-10. And we do regularly administer this to our patients so we can understand what their perception is of their swallowing function. Based on the results of those initial clinical assessments and review, we will then decide if it's appropriate to administer to the patient some different things to swallow, liquid and solid. And we have two main screening tests that we can use during our clinical exam. One is the 3-ounce water swallow test that is a screen for aspiration. With this test, we will give the patient a cup of water, 3 ounces. We'll ask them to swallow that consecutively without stopping. During the screen, we are assessing for signs of dysphagia. These would include coughing, clearing the throat, or a change in voice quality that we define as a wet, gurgly voice quality. We also have a clinical screening tool where we administer a saltine cracker and ask the patient to chew and swallow that. And then we derive metrics based on observing the patient with the cracker in terms of how long it takes them to chew, the number of chewing cycles, and also if there is any material left over in the mouth. And this will give us an indication of the presence of efficiency issues in the swallow, in addition to aspiration risks. So while these clinical tests are valuable to us, for sure, we definitely need to have these screening tests in clinic, they don't provide adequate information that we need in order to plan treatment. So I think a useful analogy in thinking about this would be if a physical therapist stood at the door of a patient with their ear up against the door, and they know the patient's at risk for falls, and they stand and listen and wait until they hear the patient fall. And then based on the sound of the fall, they create a treatment plan for that patient without knowing what's actually underlying the reason for the fall. Is it weakness in the leg? Is it a balance issue? And so this is a similar situation for us as dysphagia clinicians. If we just rely on those clinical screening tests, we don't really have any idea of what the impairments in the swallow are that are leading to the outcomes of aspiration and residue. So when determining a treatment plan, it's very important that we can visualize the swallow using instrumental assessments so that we can identify the specific impairments in the swallow and also ensure that our interventions are targeted to physiology. There's not just one type of dysphagia. There are different dysphagia profiles based on the causes of dysphagia and the medical etiology that's leading to the onset of dysphagia. So what are some of the measurements that may be useful in describing swallowing function in older adults? Well, you've already seen examples of the video fluoroscopic swallow study earlier in the talk, which is our most commonly used instrumental technique. And we can derive measures of timing, airway invasion, and structural displacement from these images through frame-by-frame analysis. And here you can see a technique where we actually place markers on various anatomic structures so that we can track them over the course of the swallow. We can also use another imaging technique called fiber optic endoscopic evaluation of swallowing, or FEES, where an endoscope is placed through the nose and into the top of the pharynx so that we can observe the pharyngeal structures and the larynx during swallowing. And here you can see an example of that. At the sort of front part of the image, you can see the epiglottis, and then you'll notice the arytenoids coming together and the vocal folds closing. And the green material that you saw in the side left over, that's an example of residue. So that's some material after the swallow that remained in the piriform sinuses. While the video fluoroscopic swallow study provides critical information in diagnosing dysphagia and in supporting treatment planning, standardization in the interpretation of these images can be an issue clinically. And also being able to derive these quantitative metrics that are so important for treatment planning through frame-by-frame analysis is very time consuming and almost impossible in our busy clinical settings. And so in order to address this, my lab has developed a collaboration with Dr. Brian Bednarz and his team in medical physics, and we're developing an AI-based clinical support tool for practicing dysphagia clinicians. And you can see the early findings of this work demonstrated here. So on the left, you can see the ground truth contours of the barium throughout the swallow that were manually derived by members of my lab. In the middle, you can see the AI predicted contours of the bolus or the barium. And then on the right, the red represents the match between the AI predicted algorithm and the manually derived contours. And the light blue shows where there's a mismatch and we need to improve upon the algorithm. And this work was initially supported by the Department of Medicine Stern Dreams Fund, which led to further funding in the form of an NIH R21 grant. In addition to improving the diagnostic instrumental assessment tools that we use, we also need risk indicators for dysphagia that we can actually measure in our clinical settings. And so another area of work for our lab is using saliva samples to identify biomarkers for dysphagia by quantifying lubrication profiles in our patients, as well as looking at the risk of pneumonia based on these biomarkers. And so this includes novel measures of salivary viscosity. We're using a technique called capillary breakup, where we stretch the samples and then look for the point of breakage. And it's been shown in other studies that salivary viscoelasticity increases with advancing age. When your saliva is more viscous, it doesn't spread throughout the oral cavity as effectively, and it's also not as able to bind to and clear bacteria from the mouth. We're also measuring levels of specific proteins, including substance P and mucin levels. Mucins have been shown to be important in providing lubrication in the swallow, and substance P is a neuropeptide that's been associated with pharyngeal and laryngeal sensation, and may be linked to the occurrence of what we call silent aspiration, which is when patients aspirate, but they don't have any response to aspiration. And so now we will be moving on to discussing the different intervention options that we have available for addressing dysphagia. When considering the different behavioral interventions for dysphagia, compensatory approaches are one type that we can use. And these approaches can be used to compensate, as the name implies, for these abnormalities in swallowing biomechanics. While this will result in improved safety and efficiency of the swallow, it will not induce lasting change in physiology. So some examples of these types of interventions include dietary modifications, postural adjustments such as the chin tuck posture, and also eating strategies, which involve sitting upright while eating and drinking, and also taking smaller bites. Recently, there have been some statement papers that have come out. This one is, there were a few here, but for some reason, the images on the slides are off. But there was one that came out in the Journal of Hospital Medicine. It was titled, "Things We Do for No Reason, Thickened Liquids for Hospitalized Adults." And there was also an article in the Washington Post that you can see here that said, "With swallowing problems, the cure is hard to stomach." And so I wanted to make sure and address some of these papers that have come out recently. So here's an example of a patient with post-stroke dysphagia swallowing thin liquid consistency of barium. And you can see that, let's see if I can get to play through again. You can see that the swallow is slow to initiate. Doesn't seem like it will play again, but the swallow is slow to initiate. And then once the swallow does occur, some of that liquid actually moves into the airway and is aspirated with that thin, watery consistency. Now here's the same patient swallowing mildly thick liquid. And you'll notice that the material moves more slowly and remains more cohesive, giving the swallowing mechanism more time to respond and preventing material from entering the airway. So we know from a variety of different studies that there are clinical scenarios with specific types of swallowing impairments where thickened liquids do result in improvement in swallowing safety or reduce the occurrence of aspiration. However, the decision to recommend thickened liquids is not black and white, it's much more nuanced. So some of the positives that you can see listed here are that thickened liquids are effective in optimizing swallowing safety. And for patients who are experiencing symptoms of dysphagia, such as coughing and throat clearing, as I've already described, those symptoms can be very bothersome and disruptive. It does reduce those symptoms for some of our patients. There is no evidence currently to show that thickened liquids increase the incidence of pneumonia. The clinical trial that's referenced in all of these papers was actually conducted here at UW-Madison, and it wasn't statistically powered for pneumonia as an outcome. We also know that thickened liquids may support hydration for patients who have a desire to have oral fluid intake, but are aspirating thin liquids. But on the other side of this picture, there is currently no evidence that thickened liquids actually prevent pneumonia. We also know that thickened liquids have poor palatability, which may lead to non-adherence to recommendations. And for some of our patients, especially our older patients, this recommendation may be misaligned with goals of care. And there are some early studies suggesting that dysphagia may be associated with dehydration, but definitely more research is needed in this space. So what do we take away from this? Well, I think the main takeaway is that there is no one-size-fits-all treatment for dysphagia. Thickened liquids and modified diets are a tool in our toolbox. They are appropriate for some patients and not for others. I think it's also a call to action for the need for larger multi-site trials to examine the efficacy of these types of recommendations, especially for older adults over a longer time frame. And then finally, we can think about thickened liquids as a short-term solution. So while a patient is hospitalized, it may be necessary for them to be on thickened liquids, especially if they're at increased risk for respiratory complications. But one of the biggest issues that we have is that many of our patients are lost to follow-up. We don't have them come back for repeat assessment. We know from some work from Dr. Kind that there are omission of dysphagia-related recommendations from the discharge report. And so this information isn't getting carried over to other settings, and then we aren't able to assess as patients' status improves or changes after hospitalization, whether or not these recommendations are even still appropriate. But regardless of, oh, okay, yep. And in order to address some of these issues with thickened liquids that I already mentioned, so the palatability concerns and the efficacy of using these thickened liquids, we are working in collaboration with food scientists here at UW through a USDA Hatch grant to do some novel thickened liquid development. And one of the goals of this work is to use some different rheological approaches, including the assessment of viscoelasticity, which I mentioned previously, to determine what are the optimal parameters of viscosity of these fluids in order to optimize swallowing function. We also want to know whether patients who have mouth dryness, so differences in the quality and quantity of their saliva, have a different experience in swallowing thickened liquids. And we'd like to understand if there are ways that we can optimize the nutritional content of these fluids for patients without affecting the efficacy of the fluids. But regardless of what you think about thickened liquids, we know there is definitely a need to move towards more rehabilitative approaches to dysphagia management. So when we think about rehabilitation, we can think about interventions that include targets for both strength and skill through exercise. And these exercise approaches will target the function of the muscles that are active during swallowing. We have various swallowing maneuvers that we can use as an exercise. These can be used as compensation. So we can ask the patient to use them while they're swallowing during a meal, but we can also have them perform these maneuvers as part of a larger exercise program. Let's see if we can get this. So here you can see an example of the effortful swallow maneuver. This is where we instruct the patient to swallow while squeezing all the muscles of their mouth and throat as hard as possible to move the food or liquid through into the esophagus. There are also a variety of device-facilitated approaches to rehabilitation. Here is an example of progressive systematic approach to strengthening the tongue. I already described to you how we can use this air-filled bulb to measure the maximal lingual pressures, but we can also use it as a device to facilitate exercise over an 8-week time frame. So we set the patient's targets at 60% of their maximum for 1 week, and then we remeasure after a week. We have them increase to 80%, and then we continually remeasure throughout the duration of the exercise so that it becomes progressively more challenging and we are able to strengthen the muscles of the tongue. This is an example of another intervention approach called expiratory muscle strength training, where patients, as you can see in this video, blow into a manometer that has resistance, and that resistance is progressively increased over the course of the intervention time frame. And this intervention has been shown to positively affect the strength of the expiratory muscles, which then translates into better clearance of material from the airway when it's aspirated. And then finally, we can use surface electromyography as biofeedback during some of those other maneuvers that I showed you, like the effortful swallow. So we can put SEMG here under the floor of mouth, and we can measure the activation of the muscles during that task. Patients can actually see how they're doing in terms of where we would like them to be so that they actually have a target to work towards during the exercise. The other thing that we can think about from more of a rehabilitative lens is how we can improve and optimize the oral environment of patients with dysphagia. So we know that pneumonia that results from aspiration is not only associated with the volume of what's being aspirated, but also the content of the aspirate. So if there's a higher load of pathogenic bacteria in the material that's aspirated, then those patients are going to be at higher risk for developing pneumonia. And there has been some work looking at the effects of a probiotic intervention on the gut microbiome, but there hasn't been much work examining its impact on the oral microbiome. So we conducted a study in collaboration with Dr. Safdar in the Department of Medicine and Dr. Thibault in the Department of Surgery to look at the oral microbial diversity of patients, older patients with dysphagia and documented aspiration. We had these patients undergo a 4-week probiotic intervention, and then we measured bacterial diversity after that 4-week time frame, and our patients had over 90% adherence to the intervention. We found increased both alpha and beta diversity in these saliva samples. Here you can see the graph showing the increase in alpha diversity as measured with the Shannon Diversity Index. This is a small sample, but it served as pilot data, and we are hoping to use this to apply for a larger grant. So despite the fact that we have evidence-based rehabilitative approaches available for use in our patients, there does tend to be a reliance on these compensatory approaches. This is a survey study of over 200 speech-language pathology clinicians in which they were presented with a case of a patient and a video fluoroscopic swallow study example. And the study revealed significant variation in the different treatment combinations that these clinicians recommended. It also showed low utilization of the mapping of interventions to the specific physiologic impairments in the swallow, and there was minimal use of exercise-based interventions. So this work really highlighted these barriers that exist in the field to translation of evidence-based practice. In order to help bridge this gap, we collaborated with a team at McMaster University in Canada to conduct a mapping review of dysphagia interventions and their impact on physiologic outcomes of dysphagia as measured with video fluoroscopy. We found that the majority of the studies in this review demonstrated some improvement in swallowing physiology following a rehabilitative intervention. And you can see on the right in this table, you can see the different aspects of physiology that were most commonly impacted with our interventions. The ones in green were the most commonly impacted. This review also highlighted that while some of these studies did have large effect sizes, only a subset reported statistically significant change, which again highlights the need for larger multi-site clinical trials that are adequately powered to address these questions. So knowing some of the barriers to implementation of rehabilitative interventions in clinical practice, we worked with the National Service Lead in the VA for Speech-Language Pathology, Nan Musson, to examine whether this gap exists in the VA system. And indeed, we found that for an individual veteran with a diagnosis of dysphagia, the average number of treatment sessions was 3, which is much too low to enact change in the physiology of the swallow. We also identified that there were no national level standardized outcomes that could be aggregated specific to dysphagia to allow us to assess treatment effectiveness. We identified a need for structured training opportunities, both in terms of evaluation and treatment. And finally, there were no established care pathways that were rooted in evidence that could provide a framework for clinical decision-making. And so to address these issues, we created the Multi-Site Intensive Dysphagia Treatment Program. IDT is a national multidisciplinary program focused on the delivery of comprehensive patient care and improving quality of life related to swallowing. The goal of IDT is to support implementation of evidence-based practice for the treatment of swallowing disorders through standardized toolkits, therapy protocols, and training resources. The IDT program was first developed here at the Madison VA Hospital in 2013 and has since been implemented at 30 sites nationally, and those sites are pictured here. To accomplish our goals, our first focus was on how we can support effective treatment delivery. So we wanted to improve accessibility to treatment by developing home therapy protocols, offering telehealth and phone options for our patients, and employing a multidisciplinary approach to care that includes the physician and the dietitian, and trying to combine all of those disciplines into one visit for our patients to make it more accessible for them to attend visits. We also provided supports to improve patient adherence to therapy by providing consistent follow-up, using logs and device recordings to gain information about adherence, and ensuring that all of the rehabilitative interventions that were being recommended were personalized to that patient's swallowing profile, and that devices providing biofeedback were used whenever possible. We also provide support and accountability to practicing clinicians by having a centralized program support to address barriers in implementation, establishing programmatic expectations and standards, and encouraging clinicians to think critically about the rationale for their chosen treatment approach. We also work to create standardization of dysphagia outcomes nationally by working with clinicians across all of our sites to develop an outcomes framework. And you can see that pictured here. So our framework starts with an instrumental assessment. This might either be video fluoroscopy or FEES, and then standardized validated interpretation tools are used with those assessments. To increase the feasibility, we did identify outcome measures that we thought should be applied to all patients, regardless of their medical etiology. But then we created a decision tree that allows the clinician to see whether or not other outcome measures might be appropriate for their population. So for instance, if you have a patient with head and neck cancer, there are specific swallowing related outcome measures that have been validated for that population. We also added in into the decision tree some additional measures that might be needed based on the kind of therapy that's being used. So if you're using tongue strengthening versus expiratory muscle strength training, there may be different kinds of metrics that you need to derive. We also focused on providing structured training opportunities to clinicians in the program by adopting an evidence-based protocol for our video fluoroscopic swallow studies. We created therapy toolkits that are available on the IDT SharePoint within the VA. We developed a series of didactic trainings for clinicians that's available through the talent management system. And finally, we hold monthly meetings for all of our sites, as well as individual site meetings to provide support and additional training. And finally, in order to create care pathways for our patients with dysphagia that guide clinical decision-making regarding which of our rehabilitative approaches are most appropriate, we created a clinical decision framework. So here you can see one branch of the framework focused on impairments in safety of or in efficiency of the swallow, and another branch that's focused on impairments based in safety of the swallow to help clinicians make decisions about what interventions are going to be most targeted for that particular patient. The infrastructure that's been established by the IDT program in the VA nationally has set the stage for research and multi-site studies. Here's an example of a VA merit grant that we're working on with Dr. Tim McCullough and his team to examine the sensitivity of a novel diagnostic approach for swallowing, pharyngeal high-resolution manometry. So in considering the ways that we can move our field forward with respect to the implementation of rehabilitative interventions, one aspect that really stood out was the low use of these types of interventions for some of our most vulnerable older adults, patients with Alzheimer's disease and related dementias. Some of our recent work through a pilot grant from Brown University in collaboration with Dr. Joan Tino has demonstrated the impact of dysphagia in this high-risk group. With this study, we accessed administrative data from nursing home residents with dementia with a hospitalization between 2013 and 2017. And we linked this hospitalization data with data from the minimum data set nursing home assessment. We were able to derive information about dysphagia status and feeding tube placement across this hospitalization trajectory. Here you can see the demographics for our final cohort, but overall, we found that dysphagia before hospitalization increases the risk of feeding tube placement during hospitalization. New onset dysphagia occurring after hospitalization was more common in our patients if they received mechanical ventilation during their hospital stay. And those patients with pre-hospitalization dysphagia who received a feeding tube had the poorest odds of survival at 1 year post-discharge. So this really shows that placing the feeding tube in these patients is not addressing the issues related to dysphagia. These findings highlight the importance of early identification and intervention for this population, and also the need for advanced care planning specific to eating and swallowing. Specific to the implementation of rehabilitative interventions for this population, my lab is conducting an NIH-funded clinical trial to test the feasibility, acceptability, and impact of 2 interventions on swallowing-related outcomes in a cohort of patients with mild to moderate Alzheimer's disease and related dementia. So participants are diagnosed with dysphagia, randomized to one of 4 arms. One is the usual care arm, and then there are 2 interventions. One is that tongue strengthening intervention that I described previously. The other is regular application of a saliva substitute. And then the 4th arm is a combination of the 2. We follow the patients then also to look at the incidence of pneumonia and hospital readmission. So now we'll move on to discussing the differences between reactive and proactive approaches to dysphagia care. Bringing us back to that clinical scenario that I set up for you at the beginning of the talk, this issue is not of identifying dysphagia. This issue of not identifying dysphagia until an acute event and a hospitalization is very common in persons with dementia and often leads to more reactive approaches to care. So what do I mean by reactive approaches? These are largely compensatory and are implemented after dysphagia is already identified. Because of this, we're not able to identify early changes in swallowing. We aren't able to induce lasting change in swallowing biomechanics. We have a missed opportunity to build physiologic functional reserve. There can be misalignment with goals of care, a lack of advanced care planning specific to dysphagia, and the disease is dictating the management plan rather than the patient. And so we have put out a call in the field to move towards more proactive approaches to care that target underlying swallowing function early before the development of dysphagia so that we can maintain an optimized quality of life longer into disease progression. And we have a couple of papers, one with a focus on neurodegenerative disease and another with a focus on patients with head and neck cancer undergoing radiation treatment. This is a multi-site trial and UW is a site for this study. And so while we aren't clear whether dysphagia progression, what the trajectory of dysphagia progression is in dementia, we don't know if it exactly mirrors decline in cognitive impairment. Our thought is that if we can implement early rehabilitative interventions for this population, we may be able to maximize function for longer into the disease. And so in line with this, within our IDT program, we've developed several proactive care pathways focused on these 2 populations. So in conclusion, I have some take-home points for you. I also wanted to highlight some work that we have hopefully underway soon in the form of our R01 submission, where we will build on pilot data that we've collected using these clinical models in the VA and UW Health data to conduct the first longitudinal cohort study of swallowing in dementia so that we can identify some clinical features of dysphagia, risk indicators, and also define trajectories of change in swallowing function. So with that, main take-home points, dysphagia is common in older adults, we know this, and it is associated with negative health consequences. Compensatory and rehabilitative interventions both have a place in dysphagia management for older adults. However, there's a need to move more towards proactive models of care, especially for vulnerable older adult populations, so that we can maximize quality of life and prevent negative health outcomes. So with that, I'd like to start by thanking my funding sources, including the Linda Stern and Family Dreams Fund and Dale Sandali and family with their contributions in memory of John Sandali. I would also like to make sure to thank my K76 mentor, Dr. Amy Kind, Dr. Asana, and all of my incredible collaborators, some of whom are here today in the Division of Geriatrics, and the members of my tenure advisory committee. I'd also like to acknowledge my team in the Swallowing and Salivary Bioscience Lab, especially Sarah Gustafson, our lead researcher, and Joanne Yee, our National Program Coordinator for IDT. I'd like to thank the clinical teams at the UW and the VA for supporting all of the recruitment on our studies. I'd like to acknowledge Dr. Joanne Robbins, Professor Emerita in the Department of Medicine, who paved the way for me here at UW. And of course, the unending support of my home team. So with that, I'd be happy to entertain any questions that you have, and I look forward to discussion. Thank you so much.
Great, wonderful talk, really fascinating. And first question is Bob. Dun, 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 dun.
Thank you. Michelle or Nicole, what do you see in terms of vitamin deficiencies in these folks?
So much for that question, Bob. So unfortunately, we don't have a lot of work looking at the specific nutritional deficiencies in our patients. There have been some studies that have shown overall lower protein intake for patients with chronic dysphagia, but the work in terms of defining changes in nutritional status is very limited at this point. So it's an area for future research. So it's a great question.
One from the online audience. What about medications and the effect on swallowing, and particularly some sleeping meds or whatever?
Yeah, thank you so much for that. I didn't have time to include it in this talk, but we actually just completed another collaborative study with Brown University and Jim Rudolph, where we looked at the impact of antipsychotics on swallowing function in a large administrative data set. And we did find some strong associations there. So we do know that medications, especially classes like antipsychotics, can have a significant effect on swallowing function by depressing the nervous system. And so this is definitely something that we have to take into account when we're diagnosing dysphagia and thinking about treatment planning.
So I think I learned something new every time I see you talk, which is kind of amazing. So in the long-term care population, which is near and dear to my heart, we run into the problem that our tools are bludgeons, not scalpels, right? And so we have people assessed for dysphagia, and then the instant response is thickening their liquids because we get dinged and federally cited if we do not thicken their liquids. It's a regulatory issue. Do you see any broadening of our repertoire or anything changing on the federal regulatory scene that would lead us not to thicken everybody's liquids?
Thanks for that comment, Alexis. Yeah, this is a major challenge for our field, is thinking about the diagnosis of dysphagia in long-term care settings. Unfortunately, one of the biggest issues that we have is that instrumentation that allows for visualization of the swallow isn't always readily accessible in those settings. Fortunately, there are some newer companies that are being developed nationwide. I think we have one in Wisconsin that I've been able to find, hopefully more in the future, that are providing mobile fees or mobile endoscopy to those settings. I think the key to changing some of these management patterns is going to be advocating for these instrumental assessments, because it can be really challenging for a clinician to devise a treatment plan if they aren't able to see what the impairments are. So it makes sense that then they're leaning on these more reactive compensatory approaches, but that it definitely is not a good solution. So I think we need to move towards advocating for access to more of these instrumental assessments, especially because now there are these mobile options.
And particularly in the inpatient setting, we often place Dopphoff tubes in patients for nutrition. How does the presence of a Dopphoff tube itself, what is the impact on swallowing?
That's a great point. So we do have some research that's looked at this, and specifically for Dopphoff tubes, there is not a significant effect on the physiology of the swallow just by having the Dopphoff tube present. However, the larger diameter nasogastric tubes can certainly impact swallowing physiology. So that's something that does need to be taken into account when we're doing the swallow study. But the research thus far, while small studies, has not shown a significant impact of the presence of the Dopphoff tube specifically.
And then you mentioned mechanical ventilation being a risk factor. In the short term, what are the acute effects of being intubated and the duration of those effects?
Yeah, so again, the effects of intubation do depend on both the method of intubation, whether it was emergent, visualized, and then also the duration of intubation and the size of the endotracheal tube. So all of those factors will play in. So in general, patients who are intubated for longer and have larger diameter endotracheal tubes in place will have more significant effects on swallowing. Essentially, the tube is sitting in the larynx for a prolonged period of time. It can affect functioning of the vocal folds and also the strength of the muscles. There can be deconditioning in the swallow. We usually do like to give some time post-extubation before we assess the patient, because there can be some sort of acute recovery that happens. But then it is important that we assess, and we do definitely see more recovery in patients with shorter intubations and smaller tubes.
So one of the things you mentioned as far as rehab was strengthening expiratory muscles. I was wondering, is there any kind of data on, independent of frailty, the risk of symptomatic dysphagia in patients with underlying pulmonary pathophysiology?
So I'm thinking, are you referring more to patients with like chronic, like
Chronic, like
COPD?
COPD,
Sure.
ILD,
Yeah.
that kind of thing.
Yes, absolutely. COPD, there's quite a high prevalence of dysphagia in patients with COPD in particular. One of the challenges with that population is that the swallowing, the presentation of dysphagia is not as consistent. So when we do like our full swallow study with maybe 14 swallows, we may see only a few instances of aspiration, or it's going to be inconsistent across the study. We think that the issues with swallowing in that population are related to the coordination of respiration and swallowing, certainly could be related to strength of the expiratory muscles. I didn't get into it here. There's an entire line of work focused on developing interventions that target respiratory swallow coordination specifically for those populations. Bonnie Martin Harris is an investigator out of Northwestern University who's pioneered a lot of that work, and we're hoping that it will become more like feasible to implement it clinically.
Okay, one last question, who promises to be short.
I feel so many times on the inpatient side, we are put in a position to start this decision tree, especially in a low risk patient, for example, who has cellulitis, a DVT, dysphagia is not on the radar and somebody brings up a concern. It seems like the data you presented, if there is a concern at all, we have a possibility to make a difference in their life. I just am curious what your thoughts are on somebody who doesn't have head and neck cancer, doesn't have dementia, and we're faced with this decision tree. Should we speak to the patient first and say we can offer these things? What exactly are your thoughts in that position?
That is such a great point. I think that some of the work that I showed looking at frailty definitely doesn't only apply to older adults. I think once patients are in the hospital, the effects of hospitalization, some of these other medical conditions that you mentioned can definitely result in overall deconditioning. So even though those medical diagnoses that I put up there are most commonly associated with dysphagia, we see dysphagia across a whole variety of patients in the hospital. So certainly it doesn't surprise me that some of those patients may be demonstrating signs. I do think that if you have concerns for signs of dysphagia, it's important to put in that consult. Let us do the evaluation, but certainly I can speak here for UW Health Swallow Service. We're very tuned into some of these complexities around patient-centered care and goals of care. So it's always a discussion with the medical team and the patient, but getting an evaluation sooner rather than later will be important.
All right, well, we are at time. I want to thank all of you for your participation and Dr. Pulia for a really wonderful talk. Nobody aspirated during the discussion, so I think always that's a success.
It's a win. Huge win. Yes.